Another important way of paying physicians we call capitation. Let's investigate that for a few minutes. Sometimes we say capitation is payment per person per unit time. Let's illustrate capitation with an example, thinking about a primary care practice. We could do this with specialists too, and we'll vary the specifics if we did that, but we'll just do primary care to keep it simple, and anyway, specialist capitation is less common. The first step in a capitation payment model is to identify a population of people that are cared for by a practice. Sometimes we'll call this the panel of patients associated with the practice. For a primary care practice, an insurer using capitation could require covered patients to identify their primary care doctor, sign up with the primary care provider, and that would make the panel. The patients are then required to see this doctor for their primary care. Then we define a scope of services to be included in the capitation arrangement. For example, for a primary care practice, we might say the scope is outpatient primary care services, meaning office visits and services provided in the office, but excluding inpatient care or procedures or tests that would need to be done outside the office. Then the practice and the intermediary agree on a fixed payment amount per panel patient per time period, which is commonly a month, to cover all the services falling under the arrangement. We might call this the capitation rate, or in the jargon, this amount is sometimes called the PMPM amount, the per member per month amount. These rates are negotiated, and they obviously have to be adjusted for the scope of the agreement, and they're also typically adjusted for at least some characteristics of the panel, like their age and sex. So this will determine payments to the practice. Each month, say, the practice gets a payment equal to the number of patients in the assigned panel multiplied by the PMPM amount. So for example, if a practice has 1,000 patients in the panel and a PMPM of $25 for primary care services, then the physicians in the practice get paid $25,000 a month, and the practice is then expected to provide whatever of the included services the assigned patients require during that time period. In a pure capitation system, there would be no further payment for any particular service. It wouldn't matter what exactly the physicians do for each patient. If those patients need lots of care, the practice has to deliver lots of care. If the patients don't need a lot of care, then they have an easier month. The practice gets $25,000 either way. If the patients need services outside the scope, of course, like they need to be hospitalized, then of course the intermediary pays for that separately. So that's the general structure: a panel, a scope, a PMPM amount, and the payments determined regardless of the actual charges or costs of taking care of the patients involved. This could be applied to many different specific situations, each with their own way of defining the panel, each their own scope, and of course, each their own PMPM. We sometimes say this is the opposite of a fee-for-service system. Why is that? Under a fee-for-service system, the physician gets paid every time he or she does a new service. Here, the physician gets one amount regardless of how many services or what exact services are provided. If they do a lot of things for the patients and their panel in a month, they get the same amount of money as if they do fewer things. And we sometimes introduce the terminology here, prospective payment. The payment here is determined before any services are provided and doesn't change depending on the services that are provided. So now you know something about the basic structure of capitation arrangements and how they work.